Welcome to Research Renaissance, presented by the Karen Toffler Charitable Trust. Embark on a journey into the forefront of cutting-edge brain science as we feature insightful discussions with a diverse array of guests, from early career researchers pioneering groundbreaking science to influential voices in investment communities, policymaking, and research institutions. Together, we delve into neurological diseases, their causes, treatments, and the quest for cures. Join us in advancing our understanding of the brain and addressing its ailments. Welcome to Research Renaissance. I'm Deborah Westphal, your host and guide through the fascinating future of the brain. Joining me today is Dr. Alon Avidan, Professor of Neurology at UCLA, where he serves as the Director of UCLA Sleep Disorders Center. Alon is also a 2020 Toffler Scholar. Today, we will discuss the relationship between sleep and Parkinson's disease. So let's dive in. Welcome, Alon. So excited to have you here, and I really look forward to your thoughts on this intersections between sleep and Parkinson's and Alzheimer's.
Thank you so much, Deb, for having me. And of course, thank you to the Toffler Trust for selecting me and my colleagues to receive funds to make this research possible. We sincerely appreciate this.
You bet. And what you're doing is very kind of new research, advanced research, and this relationship between sleep and neurological diseases is very fascinating. And I can't wait to dive in. So the first thing, can you describe the most significant ways in which sleep disorders can impact neurological health, especially when it comes to Alzheimer's or Parkinson's?
Absolutely. This question, Deb, about the impact of sleep and neurologic disease is very personal to me because I remember as a resident, as I was trying to select a specialty within neurology, that I found very few fields, very few conditions as rewarding as sleep medicine, because when you treat sleep, so many other symptoms improve. Seizures get better. Headaches become less intractable. Memory improves. People's happiness score goes up. As a resident, I remember a night when I was sleep deprived and a night when I was recovered. And boy, is there an incredible difference in the way we behave towards each other, in the way that sleep deprivation can sometimes make us see things that are not there. And those are hallucinations, by the way. And I realized that when it comes to sleep medicine, the ability of the clinician to provide a significant impact in a patient's quality of life is immense. We have more recently learned that certain sleep disorders can provide a window into some evolving neurologic conditions before they even develop. And many people are not aware of these conditions and consider them normal process of getting older, perhaps. But it's incredible that we are all required to spend 7 to 8 hours sleeping during the night. And if there was no specific evolutionary functional reasons to do that, sleep would have been the greatest evolutionary mistake of mankind. So we now realize that there is a very important reason why we sleep and a very important reason why we need to spend sufficient time sleeping. And even more importantly, why in certain individuals who are not getting enough sleep or have poor sleep, that can get them into trouble with the primary neurologic and medical condition. And Parkinson's disease is indeed that particular disease state. We realize that people with Parkinson's disease, virtually every one of them, as the disease progresses, is going to experience either insomnia or sleepiness or satisfaction with their sleep. So this is a fascinating area. And I'm so glad we're getting a chance to really delve into the various disorders that we see in sleep medicine, and particularly how it relates to brain health.
So you mentioned that once you have a disease like Parkinson's, that it disrupts the sleep. Is it also true that your research has kind of uncovered that, disruptive sleep or poor sleep might in fact even lead to the manifestation of the disease? Is that correct?
That's such an important question, that it's a chicken and the egg phenomenon, right? We think of conditions such as Alzheimer's disease and sleep and Parkinson's disease and sleep as having a bidirectional relationship, meaning that rather than considering one as a cause of the other, that we all consider them as existing at the same time and being comorbid with each other and having an impact on sleep, sleep disorders impacting brain health and brain health impacting sleep in a way that doesn't establish a direct causative relationship on the primary condition, but rather having a bidirectional relationship. So, in other words, if people with Parkinson's disease, as a disease progresses, insomnia becomes more severe. As insomnia becomes more severe and people's poor sleep begin to manifest as not sleeping sufficiently or not sleeping well at night, that in fact has a direct impact on their quality of life and on the management of the Parkinson's disease.
So there's different kinds of sleep, and you're the expert, but there's REM, there's deep sleep, can you explain these different types of sleep and what role does each of these have just in normal, a healthy brain, but then also how do they impact the disease or over time, the manifestation of the disease?
Absolutely. And that is a really important because we realize more recently that there are certain reasons and often specific disturbances that we see in a specific sleep staging and what this tells us about the primary neurologic condition. As a general rule, as we get older, we're spending time, it takes us a little bit longer to fall asleep. We're also finding out that we're spending less time in deep, slow wave sleep. Deep, slow wave sleep is also called delta sleep. This is a type of sleep that is restorative, it's rejuvenative. But after age 40, every one of us has a decline and a reduction in REM sleep. It's predictable. We find that some very, very interesting phenomenon is that the brain has its own filtration system called the glymphatic system. Glymphatic is after glial. The glial cells are what makes up the neurons in the brain. And glymphatic means that a lymphatic system in the brain that is supposed to filter out and remove proteins and toxins from the brain. And that filtration system is only active during the night and is primarily linked to slow wave sleep. During delta sleep, that's where the filtration takes place. So one important issue to be reminded of is that in people with Alzheimer's disease who experience a very significant drop in slow wave sleep, the ability to filter out and clear the brain of proteins and toxins and metabolites, it doesn't happen very efficiently. But we realize that if we increase slow wave sleep in people with Alzheimer's dementia, that you can actually improve the lymphatic clearance and get rid of those abnormal proteins. And this might be considered a disease modifying therapy in a way, that you're actually making a change in the underlying pathophysiology and pathology of the disorder. Now, there is another type of sleep stage. It's called REM, or rapid eye movement sleep. And what we do in REM is we dream. And part of the importance of having REM sleep is memory consolidation. It also has a restorative function. And we know that we absolutely need to get into REM sleep because, after all, every time we recover our sleep after a long period of sleep deprivation, we dream a lot. So it means that we're spending more time in REM. Now, why is REM so important as we talk about brain health? It turns out that the mechanisms in the brainstem that are responsible for control of muscle tone is generated in the brainstem, and it's generated to keep us paralyzed, protecting us from acting out our dreams. After all, if we all went through REM sleep and our muscle tone was elevated, then we would all be acting out our dreams. In Parkinson's disease, and in a condition that precedes Parkinson's disease, the mechanism in the brainstem that is protective and preventing us from acting out our dreams is defective. So your question about the sleep staging and with particular relevance to Parkinson's disease is that REM sleep is abnormal in people with Parkinson's disease. Many of them, up to 30%, will experience episodes in which they're acting out their dreams. This is called REM sleep behavior disorder, and you must make a diagnosis after evaluating the patient with a sleep study as well to demonstrate that the muscle tone is abnormal. But if we find that patients are acting out or fighting at night, even without the presence of Parkinson's disease, this may be the very first clue that the patient may be on their way to develop Parkinson's disease. In other words, when we see patients in their 40s and 50s without any neurologic condition, and we determine the patient has REM sleep behavior disorder, meaning that the patient experiences episodes at night in which they're fighting during sleep, and having abnormal muscle tone instead of being paralyzed, and the muscle tone is actually expressed, that is a sign that the patient may go on to develop Parkinson's disease later in life. Going back to, well, why is this so important? Well, the very fact that we can diagnose a condition like RBD early on is an incredibly important opportunity to then determine if this is a patient who may benefit from treatment that could help delay or even prevent the onset of the neurologic disorder, i.e., Parkinson's disease. And this is really central to many research projects that are currently underway to help understand who are the patients at greatest risk, to help us understand eventually when the medication becomes available, how we might be able to track and follow those patients for clinical improvement.
So is this pretty new science then, this understanding of the brainstem and its malfunction when it comes to sleep? Because, growing up, or as a parent, children have night terrors and they flop their arms around or they may sleepwalk. And, we don't think too much about it. If you did that as a kid, maybe you do that still as an adult. It's maybe dismissed as well. I just never outgrew it. Can you just kind of elaborate on the difference between these night terrors that a kid has and what goes through as an adult? And is this new understanding and new science that is being worked and understood?
Absolutely, absolutely. So I'll go over the second question first, which is this new science? Is the whole notion that people act out their dreams, is this something we're just realizing now? The answer is no. In fact, Dr. Parkinson's, the clinician who first described Parkinson's disease, in the essay of patient number six in his description was a gentleman who was agitated at night and was moving in a way that was abnormal, as if he was stricken by different spirits. But this is essentially a description of what we would today diagnose as REM sleep behavior disorder. Moving on to the Walt Disney. Walt Disney depicted some characters in Cinderella, for example. In Cinderella, Cinderella's dog was experiencing all these abnormal movements, and which were thought to be nightmares, but they were actually episodes of REM sleep behavior disorder. It was in 1965 that Jouvet, who was a French neuroscientist at the time studying at the University of Lyon in France, who discovered that cats who underwent a lesion that affected their brainstem in their REM generating centers ended up having predatory behaviors during the night, very much acting out in a predatory fashion what they were dreaming about. Of course, the cat would be running and chasing after a supposed mouse in those classic videos that he was able to record and demonstrating the cats were in REM sleep, but their muscle tone was, instead of being paralyzed, it was abnormally elevated. That's the first animal model that this condition existed. 1986 was the first description of RBD as a parasomnia, and I'll define parasomnia very shortly, by the Minnesota group, which was led by a clinician, a dear friend of mine, Dr. Carlos Schenk, who first coined the term REM sleep behavior disorder. So 1986, that's, we're getting into almost 40 years of knowing about the condition. And within that time frame, Dr. Schenk has also determined that the group of patients that he followed who first developed this condition, the majority of them went on to develop a neurodegenerative condition, which is why this is so important to our audience and to brain, why we're speaking about RBD today. So RBD is REM sleep behavior disorder, is a parasomnia. Parasomnias are abnormal behaviors or experiences that patients may experience normally in childhood. Nightmares are parasomnias. Sleep terrors are parasomnias. Sleepwalking are parasomnias. Most of us outgrow these parasomnias, and in fact, in some age groups, these events are completely normal. You almost anticipate that the child will have these events, and the reason for that is the brain undergoes maturation, and during the maturation process, there are often abnormal behaviors that may manifest, and they are merely phenomenon that are reflective of normal brain development. A parasomnia is this behavior that the individual experiences that may be perceived as abnormal. Movements, yelling, speech, visual experiences, sensory experiences that occur during the transition from one sleep state into another. Now, sleep terrors are parasomnias that occur during non-REM sleep, non-dream sleep. So the child usually wakes up with a scream, fear. There isn't really a dream experience. They seem to be very agitated. They don't really respond to their parents. And then after a minute or two, the episode goes away. And the child doesn't have any clue of what they did the next day. Sleepwalking is the same. Sleep and nightmares, or nightmares are like a REM sleep behavior disorder, are parasomnias that occur during REM sleep. So there is usually retention of memory. The patient can tell you about a nightmare. And it's very different than RBD in that patients with nightmares never get up, they never look agitated, they never move, they never, besides screaming, they don't really act out anything. And the child is generally, they may have a few episodes like this a couple of times a month, and then it goes away. But RBD, REM sleep behavior disorder, is much, much more elaborate. It, besides the abnormal dream mentation, the patient sees things that are very frightening or disruptive. They react to the dreams in a way that can put them in danger, both the patient as well as the bed partner. So, for example, the patient may feel that they're being confronted by animals, or there is a swarm of bees trying to attack them, or an intruder that is coming to the house trying to chase them. So the patient often needs to defend themselves, and in so doing, they may hurt themselves and hurt their bed partners, thinking that the bed partner is actually the intruder. And that's why symptomatic treatment for this condition is so critical.
So I'm, as you're talking, I'm reflecting on my annual physicals, and I don't think I've ever recalled my physician ever asking me about my sleep. Like, it's other questions. It's, your appetite and exercise, and they do a lot of diagnostics on blood and all that. But I've never been asked about, do you sleep well and do you sleep rested? Or have you ever had any of these type of episodes where you're acting out your dreams? Is this something that, physicians normally ask, or is this a diagnosis that just goes, unseen, to even start the question about a diagnosis or kind of a precondition for Parkinson's?
Deb, I'm so glad you asked me this question. And it brings to attention the fact that sleep medicine education in the United States and the world is lacking. Just to give you an example, the number of hours that are spent during the entire medical school curriculum on sleep is merely an hour and a half to 2 hours. And that's talking about sleep physiology, narcolepsy, parasomnia, sleep apnea, insomnia, and it's just not enough.
And this is 1 or 2 hours of instruction over the schooling to become a physician?
Exactly, during the entire 4-year curriculum.
Oh,
Not enough, not enough.
wow.
Yet we spend a third of our lives sleeping, and physicians are not well educated about sleep. And by not receiving this education, it's not on physicians' radar screen to ask patients, how are you sleeping? And I'm just amazed that particularly during the pandemic, almost every patient whom we saw had problems with difficulties falling asleep and maintaining sleep. People were worried. Even now, before they watch the news, they watch the news at night, they get worried, and then they can't fall asleep. But part of the problem also is that physicians may not know what to do when the answer is yes, I have insomnia, or yes, I act out my dreams. Most physicians are aware that if the patient snores and stops breathing or experiences daytime sleepiness, that they should probably undergo a sleep study. Most physicians would know that, well, if the patient has insomnia, there are a number of hypnotic medications that they may be prescribed, or some may even send the patient for cognitive and behavioral therapy. But most physicians would not know what to say to patients about parasomnias. So I'll just give you data. At UCLA, we have followed a group of 30 patients with isolated RBD before the patient developed Parkinson's disease. And here's what we found. The lead time to diagnosis from the onset of the symptoms until the patient received a diagnosis of RBD was 15 years. 15 years. The reasons, patients were told the following as potential explanations to their abnormal dreaming. A, you're having a nightmare. B, you're having a sleep terror. C, you have Parkinson's disease. And this is without any further confirmation of the condition. Some patients were told this may be related to too much pizza they've had the night before. Some patients were told it's perfectly normal to act out your dreams. And 2 patients were diagnosed with RBD at presentation, not because the physician determined that that was the cause. It's because the patient went online and found their diagnosis, found that what they had was probably representative of dysparasomnia, REM sleep behavior disorder, and the physician seemed to agree with that diagnosis. And here's the patient teaching the physicians about their condition and the physician not knowing about it before. So this is fascinating, I think. And it just talks about the fact that there is severe under-recognition and appreciation of this diagnosis. The worldwide epidemic of RBD is probably 1%, 80. So it's that 80 million individuals worldwide. This is the same epidemiology as schizophrenia. So it's not a rare condition. It's common. It's just not recognized. And it's important to recognize, of course, because patients may injure themselves, but particularly because this is a diagnosis that is prodromal. It's predictive of a serious neurologic condition even before the neurologic condition manifests itself.
And that's why this research that you're doing, that connection between the REM sleep and Parkinson's, is very important, because you said 15 years to get to the diagnosis of RDB or to Parkinson's?
To get to the diagnosis of RBD.
Of just RBD,
yes.
Just to RBD. That's that is 15 years where your brain is not going into the REM sleep, which is cleaning out the crud, if you would, out of your brain that is needed to restore some of the connections for the memory and just brain health. That's a lot of years to let things build up. Am I understanding that correctly?
It's slightly different, and I think that we were talking about the lymphatic clearance occurring during slow wave sleep in people with Parkinson's. And You're right, that is very common in people with Parkinson's who don't have sufficient sleep continuity and are not spending enough time in delta or slow wave sleep, and that's where lymphatic clearance is important. We don't really understand if that's the same mechanism in REM sleep behavior disorder. RBD is a parasomnia that is predictive of a prodromal synucleinopathy. And alpha-synucleinopathy, let me define that as an abnormal misfolding of a protein called alpha-synuclein. People with alpha-synucleinopathy have a risk that may eventually manifest as one of 3 different conditions. Alpha-synucleinopathies, as a general group, is a group of conditions that would eventually create a path to either Parkinson's disease, dementia with Lewy bodies, or multiple system atrophy. All three are considered alpha-synucleinopathies, but they present clinically a little bit differently. So people with Parkinson's disease generally present with a tremor or abnormal movements. They may not be able to move very easily, or they may find that they're a bit rigid, or their walking may be affected, or their handwriting or signature may be affected. People with multiple system atrophy will experience conditions that are referred to as dysautonomias, which is the patient may find it difficult to get up from a chair without feeling a bit lightheaded, or they may experience frequent episodes of urinary frequency at night and sweating difficulties or erectile dysfunction. People with dementia with Lewy bodies will develop memory and cognitive disturbances, agitation, and hallucination as the very first symptom. And those patients are generally, from a cognitive perspective, generally do worse compared to the other two. The reason why it's important to think about those potential diagnoses is that if a patient with REM sleep behavior disorder presents, then any of those are likely, and the rates in which patients may eventually phenoconvert, meaning going from having a parasomnia like REM sleep behavior disorder to a parasomnia with a neurologic disease, varies considerably. We used to tell patients that, well, the risk is probably 6% per year. And then you can have a risk that varies anywhere between 50 to 80% within 10 years. And we realize that that's a pretty large risk to give to all patients. And we now realize that it really depends on the age of onset, in that if the age of onset of the dream enactment is below age 50, that the phenoconversion is more like 1% per year, and then it's 2% per year if the onset is after age 50 but below age 60. It's 4% per year if it's older than age 50 but under age 60. And then it's 6% per year over age 70, which is the highest risk. So we know that it's really age dependent, but it's important for neurologists to appreciate that this is a risk. The parasomnia signifies a risk factor, and the risk factor goes higher if the patient also has other neurologic concerns like memory, cognitive disturbances. We're now realizing that losing a sense of smell, constipation, orthostatic hypotension, difficulties with having abnormal motor exam is a risk factor. And that sort of gives you an idea that here's a patient who would likely phenoconvert very quickly if they have, besides the RBD, if they're older, if the presentation is over age 70, and if they have other biomarkers that we're now beginning to appreciate. And this is part of our research that is partially funded by the wonderful foundation, that this is really what helps us understand and create a signature marker of who will develop what and how quickly they may develop the condition. And the Toffler Foundation is really helping us understand that there might be some biomarkers that we can use together with the diagnosis of RBD to also differentiate who will develop a Parkinson's disease, dementia with Lewy bodies, as well as a Parkinson's disease. And this is work that I'm doing in conjunction with a colleague who is actually a neuroscientist in my department and is a chemist. His name is Dr. Gal Bitan, and he developed a blood test that can determine and evaluate whether the patient has specific components in their bloodstream coming from the brain indicating that they may be at risk for, or whether or not the neurodegenerative process is already happening, so we can potentially address those patients in the future as the most urgent folks who would benefit from treatment expeditiously. Right now, of course, is the time in which we don't yet have a neuroprotective medication. We do not yet have a medication that even slows down the phenoconversion, or since we know that there is a smoking gun and we know that there is a risk, the only thing we tell patients is to exercise 1 hour a day, just to get them to sweat up a little bit and to get their blood pressure higher. I'm very optimistic that within the next 5 years, we will have a neuroprotective intervention. And because an alpha-synucleinopathy is an abnormal misfolding of a protein, it may not be a drug, but it may actually be a vaccination, because the process is most likely an autoimmune process, and treatment or intervention that is aimed in preventing the abnormal protein formation is what might just eventually be the treatment of choice. But I'm very excited that so many people are interested in RBD, so many people are interested in sleep, and primary physicians will eventually learn to appreciate that sleep is really that critical question. It's one question to ask people is, how are you sleeping? How is your sleep quality? And most importantly is to ask the bed partner, how is your husband or wife or loved one sleeping? Because most patients with RBD are asleep. They are not aware of that they're having this behavior. Some of them will remember that they may have had a bad nightmare, or they might have been moving abnormally, but the most reliable observer is really the bed partner. So the bed partner needs to be on the lookout for these conditions. And unfortunately, most patients, when they come into their doctor's office, they don't come in with their spouse or family member, which is why the clinician really has the responsibility of having good collateral data and inquiring and asking family members about loved ones with abnormal movements to really get to the right diagnosis.
Yeah, that's fascinating, especially given if you're a little bit younger, around that right before you're 50, a little after 50. If you catch it early, if you can diagnose it, in the future here, there may be some sort of therapeutic that could, stop, slow down, reverse this horrible disease or diseases, because Lewy body is not good either. It's very devastating. And so that's huge. That's huge. That diagnostic that you're developing is very interesting. You made the comment about, right now it's just getting people to exercise for an hour, kind of sweat it out, get the blood pumping. Is there a relationship with this new kind of understanding of our blood-brain barrier there? Is there any connection with your research and trying to understand that through this brain stem and, the blood-brain barrier and what we're finding out there?
Yeah, the point about exercise is actually coming mainly from the Alzheimer's disease data, showing that exercise was the only intervention that actually seemed to slow down somewhat, or perhaps impact positively rates of progression. But we've just taken this information and adapted it to Parkinson's disease, because there's really nothing else that we know about. But the idea of improving sleep timing, allowing patients to benefit from the restorative power of sleep is absolutely needed. People with Parkinson's disease, unfortunately, they're faced with a severe sleep maintenance difficulties. And part of the reason is they need to get up every half hour, every hour to empty their bladder because they experience, say, episodes of nocturia, frequent urination at night. And that is probably the number one issue in many of the patients with Parkinson's is that they have such a hard time with being able to maintain sleep. They're also very rigid. And they experience discomfort with the more advanced stage of the disease. Plus, there is some new data showing that the circadian timing, the sleep-wake timing, may be disrupted, and getting patients to spend more time outdoors in the morning, particularly, would be helpful. The sun, the eyes have two functions: vision and circadian physiology, and many people who are spending the days indoors and are not getting light exposure are likely to suffer from sleep-wake irregularities. So sleep duration is key. Sleep timing, going to bed and waking up at the same time, is absolutely needed and to be maintained consistently, because all other physiologic functions in the body are really dependent on that sleep-wake timing. And if the secretion of insulin and blood glucose regulation is irregular, people are going to run the risk of diabetes. And we find this phenomenon occurring in individuals who have poor circadian regulation and are sleeping at irregular hours, particularly in folks who have a delayed pattern of sleep, going to bed late and waking up late. So there's just so much to be said about just not the quantity of sleep, the duration, the regularity, but also trying to understand if people have insomnia, sleep apnea, parasomnias, and we realize really that the window here, the window of opportunity, is specific to an underappreciated, under-recognized sleep disorder that most people attribute to nightmares or sleep terrors. That is the one signal, most reliable indicator that a patient may be on their way to develop Parkinson's disease. So rather than thinking of RBD as kind of a terrible condition to be faced with, we in sleep medicine look at it as a gift, because we know that this is a patient whom we need to follow closely. Why is this important to the patient? In the long run, if the patients are able to identify themselves as having prodromal alpha-synucleinopathy before the onset of the neurologic condition, then they're going to be prime candidates to receive treatment that could delay the presentation of Parkinson's later in life. So in a way, having this early sign is going to make those patients the most prime candidates for neuroprotective intervention that would eventually help them be enrolled in clinical trials to help delay or even prevent and intervene with the risk of developing a neurologic condition down the road. And that's very powerful. Most of the time we're using DAT scans and imaging, and those are expensive. Not everyone can afford them, and most insurance companies would not cover them unless there was a reason. So I think having a signature marker of a disease that predicts neurodegeneration that can be established with fairly good reliability following a sleep study is that smoking gun that we're looking for in pursuing future neuroprotective clinical trials aimed at, say, managing Parkinson's disease before the condition affects the brain, before it's too late.
Yeah, and all of this that message is so important, especially in a culture and society that kind of applauds those that can go on 2 hours of sleep a night and for days and days and days on end, or people that, work all night and get up for a few hours, or, we kind of make those people heroes. And, there's a lot of kind of misrepresentation of how important, sleep is not a luxury, as some people would say. Is like, well, I'll just sleep when I'm older. It's what we're doing as young people that may be leading to some of these diseases.
So true, so true. And it's you just hit the nail right on the head, Deb, because I think that the paradigm is shifting, and it's shifting. It has begun to see this change. We've seen it since the even in the early 2000s, when the work hour restrictions on residents started to go into effect, limiting the work hours to ensure physicians were able to get sufficient sleep. But I'll tell you, even though we've done it and residents are getting have less call hours, we don't really know if they're actually spending all this extra time sleeping. They're probably catching up on other things, but it's important to send the message, of course, that sleep and sleep deprivation is a this is not about heroism or getting by on less, because people make mistakes when they're not getting enough sleep. This is well established in the transportation industry and pilots, and there are specific regulations that give pilots sufficient break time and sufficient time off work to recover. And that recovery is critical, because in the healthcare industry, in taking care of patients' lives, we there is no margin of error that can be as protective as giving people sufficient time to recover. But patients need to be aware that if they cannot accept getting by with less sleep. If they experience insomnia, if they experience daytime sleepiness, they should absolutely let their clinicians know so they can get the proper treatment. And particularly if they have abnormal movements at night, dream enactment, and a dream enactment, they shouldn't settle to anything less than have you see a sleep physician to be sure we have the right diagnosis, because this is a condition that predicts neurologic disease down the road. And having that well-established diagnosis can help people enroll in clinical trials when they're available, because that's where we can intervene. But we need the patients to declare themselves before we can do that. And that's why primary physicians really need to be better at screening those patients and doing so more universally. And where part of our research also is at working on interventions and techniques to improve primary care physicians' ability to screen patients correctly and accurately, so everyone can benefit from having the diagnosis made early on in the course of their journey.
So I know you just recently finished up a book, and it's going to be published, I believe, sometime next year. What is the topic of the book, and is it about the sleep in your research?
So the textbook I'm completing is the title, The Review of Sleep Medicine. It's the 5th edition. It's the one of few textbooks that are published specifically for sleep physicians who just want to have a good resource to go to into reviewing everything they need to know about sleep medicine. It also has an assessments section, so if they have to go through the American Boards of Psychiatry and Neurology and maintenance of certification exam in sleep medicine, that they can successfully do well on those exams. So the textbook is really both a review, an assessment, and with the ultimate goal of helping all sleep physicians succeed in their careers as sleep physicians by keeping them aware and up to date on all facets of sleep medicine. So the textbook is going into the science of sleep, to the clinical diagnosis, to management, how we classify sleep, and then it also includes a couple of chapters assessing patients' knowledge, not patients, clinicians' knowledge in the various disciplines related to sleep medicine.
So I know sometimes textbooks are pretty heavy and pretty detailed. Will this be available for the general public, that if they're interested in just understanding? Because you just talked about how important sleep is for just overall health of individuals. This would be something that would be available to people too.
Yeah, anyone can purchase the textbook, but I don't think it's going to be useful to the general public because it's written at the language that is aimed at clinicians who manage patients and take care of patients and are required to make a diagnosis. There are very excellent textbooks and handbooks that are available for the general public. I'll give you some examples. Why We Sleep by Matthew Walker at UC Berkeley is a really nicely organized handbook on the various theories why we sleep, what happens when we're not sleeping well, and some anecdotes on and recommendations on how to achieve better sleep. And Dr. Walker did a really nice job summarizing the data and providing some nice charts and recommendations that patients may be able to adopt. Dr. Sonia Nkoli Israel from UC San Diego has published another book that is titled All I Want is a Good Night's Sleep, and it's focused on strategies to improve sleep. It went through probably has multiple editions, but Dr. Nkoli Israel is a very, very well respected clinician, clinical psychologist who is respected in the field and has written the book with the intent that it's going to be used by patients who may suffer from insomnia or sleepiness. There are other textbooks that are available, but the two by Nkoli Israel and Walker are probably the ones I generally recommend that the general public can probably benefit from the most.
Yeah, thank you for sharing that. I also wonder about technology like wearables, and I wear a Fitbit. I look at my sleep, profile in the morning. It shows REM and deep sleep and kind of this light sleep. Are these things, are they kind of helpful to people? And where is the technology going to kind of help people be more proactive in getting more and better sleep?
I'm so glad you are asking me about wearables, because when there is concordance with how the patient sleeps, if the patient sleeps lousy and the device shows that they are having poor sleep, it helps. When there is disconcordance, the patient feels great and the device tells them that they're not sleeping well, there is a problem. Similarly, if the device tells them that they're sleeping great, but the patient feels lousy, it doesn't help. The wearable devices, they're not the holy grail in detecting and validating sleep. The only way we can do that for sure is through clinical assessment of the patient and sleep diagnostic tools that have reliable data. However, I do use it because patients who are worried about their sleep and have a device that they can use to track and see how well they're doing, that can actually be used as a tool to validate that when we start them on treatment and the device tells them that their sleep is better, that helps. That's validation that the treatment, the intervention, whatever treatment we give the patient is actually bearing fruit. So I would say that we really need to market or describe how patients should be using this wearable devices. We want to make sure that there is a alignment first, and the intervention actually then allows the patient to track and see that they're actually doing well. And when the patient is actually paying attention to their sleep by using the wearable data, then that's therapeutic intervention by itself. So the fact that people are paying attention and going to bed at a regular time and dedicating 7 to 8 hours to sleep, and the device is helping to reinforce that, is great. We just don't want the wearable data to serve as a source of insomnia. And there is a terminology that is used to describe that sometimes the wearable devices can by themselves trigger insomnia. We call this orthosomnia, when the devices are actually doing the opposite and they're creating problems where the patient is very anxious and upset and why they're not getting good sleep, and the device is telling them that they're getting lousy sleep. So we just want to be sure that the patient understands that this is not diagnostic data that we can use reliably. But if there is a trend and the trend shows that the patient is performing well, they can use the wearable data to just guide them to verify and give them validation that what they're doing is actually bearing fruit and is useful. We see that very effectively in a management of insomnia. So, for example, if the patient has a hard time falling asleep, maintaining sleep, and then we send the patient to undergo cognitive and behavioral therapy. And during those initial months of treatment, the patient also uses wearable devices. They can actually see and track the improvement that they're seeing with the cognitive and behavioral therapy. So being able to track and actually see that the patient is progressing well and is doing better and better with each successive session of cognitive and behavioral therapy is very useful, and it provides patients an additional feedback that what they're doing is actually helping them, rather than relying on a sleep diary or the word of their therapist that they're doing well. They can actually track and see that. And when a patient participates in the process, it helps underscore the shared decision making that is so critical in managing patients with sleep disorders. And that's something we haven't brought up earlier. But shared decision making in sleep medicine is so critical, because when the patient sees the value of managing their condition, participating in it, knowing what this data means and why it's important to continue to track, is absolutely needed. And I think we as clinicians will be much more successful when our patients are able to participate as equal partners in that uh, dialogue, and ensuring that the management that they're receiving is actually, they can actually verify and monitor and describe to us when there are some instances where their performance may not be as predicted. So it's useful overall, I think.
Yeah, and you're talking about all the needed education that is, not only for clinicians but individuals, and the textbook that you've written, or the textbooks that you've written, go along with that kind of that education and teaching. And I believe you were a recipient of a Excellence in Education Award. I think it was given by the AASM. And, obviously you're very much into the education and why this is important. And not only, the education, but you're a clinician, and then you're also a researcher. But what are there innovative educational strategies that you're finding as you talk about this paradigm shift to understanding why sleep is important and how we need to take responsibility? Are there things that you're doing or you're seeing to educate?
Yes. So your question is, can be applied both to clinicians and the public. I'll start with the public first, because after all, the public is our the viewers of the episode. And we do that through providing more and more educational information to the NAPS Consortium website. NAPS stands for it's the North American Prodromal Synucleinopathy Consortium on REM sleep behavior disorder. You can Google it by putting RBD and NAPS, NAPS, and you'll find it. But this is really the central curation of information relative, specifically related to REM sleep behavior disorder in the clinical trial that we currently have with the NIH, and some of the articles that we're writing and what the articles mean. And it's specifically catered to the public, patients, and family members of patients with RBD. I'm also working with UCLA on an extension course that is specific to the public, focus on sleep health. And this will take place, the course will take place this winter, and it will be open to the general public or anyone who is interested in learning more about sleep. It will be an online class, and I have previously taught at UCLA Extension, which is open to the public. And I'm really, really excited to make that attempt yet a fourth time this fall of 2024. Finally, there are every once in a while, we put together patient webinars that are specific to RBD, and anyone who is interested in participating or learning more about them should sign up at the NAPS Consortium. You don't have to be a patient. You don't have to be a family member of a patient with RBD, but as long as you're interested in the condition, you can sign up and you can listen and participate in webinars that are focused on REM sleep behavior disorder and its associated conditions. For physicians, we are always putting together continuing medical education courses, CME courses in sleep. Most of them are virtual. We just gave one last month in May. It was a full day CME course that was virtual, and I will be conducting a few more this December through continuing medical education. So that is part of the need to ensure that sleep medicine is not it's not delivered once in one's medical career as a physician, but it's continuous. It's ongoing education. After all, this is a very, very dynamic field that sees many, many changes. And what we know about RBD and everything I said about RBD now will probably change in a year or two. It may no longer be accurate in 3 or 4 or 5 years. So being able to grow and learn and appreciate the changes in how we make diagnosis, how we manage these conditions is absolutely critical. So being able to continue and participate in the ongoing continuing education, both of patients and of our colleagues in sleep medicine, is really what makes my life interesting and challenging at the same time, but also fulfilling, because I know that the ability to benefit from each other's, we benefiting from what we hear about how patients are presenting, patients understanding more on what to look for, and patients also educating their clinicians, their primary clinicians, on conditions they may know more than the physician themselves, given that they've only had about 2 hours of sleep medicine education in med school. We often see that the patient is actually the person who knows more than the physician, and that's the irony. That's the paradox of talking about sleep medicine, and sometimes the patients are actually the ones who are telling their physicians that this is a condition they have and this is what they should benefit from in terms of treatment and evaluation.
So how do you sleep? Do you sleep well? You're very busy.
Yeah, I wish I could say that. I strive to. I try my best, yes. But it's I do know the consequence is poor when I've not gotten enough sleep before my sleep clinic, and trying to keep my eyes open is never a good idea. So I try to get sufficient sleep, so at least I can look rested, and I can have I can, when I send a message, I feel that I have some credibility because I also sleep sufficiently, and I'm not telling patients just to do it without practicing my own as healthy sleep hygiene as I can.
Yeah, set the example. So as we wrap up here, you've already talked, about some very hopeful things in the future, the diagnostic tests, some possible therapeutics that may be within the next, 5 to 10 years. That's very exciting. What are you the most hopeful for when you think about the future?
That's a really I know it's probably one of your final questions, but it's the most important one. Is, well, what is going to keep us most on the edge as we are looking at the next 10 or 15 years of our field? And I think what makes me feel very hopeful is the fact that we're very close. We're very, very close to understanding that the treatment, the ability to manage a neurodegenerative condition like Parkinson's disease will forever change, once this intervention is going to become available, because we know they most likely patients who will benefit. We already know who they are because they've already participated in an assessment of their REM sleep behavior disorder, and we can follow them. And once they get enrolled in this studies, I think what created or interfered with the ability to move and make this process go faster is the pandemic, the search for a vaccine to combat COVID-19. But I think this is not necessarily a bad thing, because immunologists and researchers who are very interested in understanding immune pathology are already looking for the next frontier. So being able to consider an alpha-synucleinopathy, that next frontier, as a condition that we need to address, that we need to hopefully prevent those proteins from being misfolded and creating the brain pathology that we see in early Alzheimer's, as patients say transition from prodromal isolated RBD to an alpha-synucleinopathy, will be that next frontier. And having that intervention will, for the first time ever, be the one treatment that can help delay, if not prevent, a neurodegenerative disease before it happens. This is amazing. As a resident in neurology, I never thought that in my lifetime we would be able to reverse a neurologic condition before it occurs. This is the first time. And it's not science. It's not science fiction. This is science. And being part of taking part of in the effort to achieve that is really what makes my getting up in the morning and going to work and making this job so fulfilling, because it's contributing to my ability to think that there is an answer out there, and we're within reach, a very, very close reach, and the ability to contribute to the science and understand more on what the disease is and how quickly we can conquer that neuroprotective medication would be incredibly fulfilling. So I hope we get there fast and quickly, because the patients are asking us. They're asking us, doctor, tell us what we can do. We know that there is a risk of a neurologic disease down the road. What can we do? And right now, we don't have the answer. And once we do, I think everyone will be thrilled to be able to finally come up with a treatment that can offer patients that ray of hope that this is a condition that we can finally delay or even prevent. So I'm very, very hopeful that we get there fast, but we can't get there fast if we don't do it together. And we can do it without getting and having and benefiting from wonderful support like the one we received from the Toffler Foundation that can help provide the infrastructure to allow us to succeed and allow us to collaborate together to look at new innovations and new strategies that can make this happen. And it's incredibly fulfilling and exciting to see that there is so much ongoing interest and support of our research. And I sincerely appreciate being part of the podcast series, Deb, and being able to benefit from the Toffler Foundation's support and for their endorsement. It's incredibly appreciative.
Yeah, well, we appreciate you and your time spent, and you paint just a fantastic future that some of these diseases that not everybody has to suffer, and hopefully people listening here will reach out and give additional support. Whether that's potential patients or potential funders that want to help you, and that would be amazing. So as we wrap up, and that question about how do people get a hold of you and contact you for whatever that might be, how do people reach you?
If people are interested in enrolling and learning more about RBD specifically, I would turn them to the RBD NAPS website, because it has the names of the study coordinator who can then put me in touch with the patient. If it's a general question about someone wanting to speak with me or see me in clinic, they can reach me through the UCLA Department of Neurology. They can Google my name, and UCLA has the ability of patients to send messages directly to physicians through the UCLA website. And if there are any questions related to our research or wanting to be seen in our clinic, the UCLA Neurology Clinic allows them to place a call and request a consultation. We're happy to see folks if they want to be seen specifically for their sleep issues, and certainly I can make myself available to assist with that as well.
Thank you so much for your time today. You're so busy, but your message was simple and understood, and I hope others feel the same way. And just really appreciate your dedication and the energy that you put towards all of these efforts. So thank you very much.
Oh, you're so welcome, Deb. And if you need to have me back to have a follow-up, if there are any questions, feel free to reach out. Certainly, if you have any more questions or comments, what I'll do is I'll share with Deb the websites that I mentioned earlier, so you'll be able to probably use a link, or we'll make that process easy for everyone. But I really appreciate you joining us and learning more about sleep, and something we all strive to get more of, and to let Deb know that I will be sharing all the resources on reaching out to me in the future. Thanks so much for joining us.
Thank you for joining Research Renaissance. For more information and to stay updated, subscribe for more episodes and visit our website at tofflertrust.org. Feel free to call us if you have any thoughts, suggestions, or just want to find out more about the Karen Toffler Charitable Trust. Until we meet again, onward and upward.